This topic is tracheoesophageal fistula, also known as TEF, and esophageal atresia. Tracheoesophageal fistula, or TEF, and esophageal atresia are congenital malformations. These can occur in combination with one another or separately. Atresia is a part of the body that is closed or absent. So as you can see in the illustration, the proximal esophagus has formed a blind pouch. A fistula is an abnormal connection of two parts of the body. So as you can see in our illustration to the right, the distal esophagus has attached itself to the primary bronchus, or the trachea. Both of these conditions or malformations increase the risk for aspiration, which can lead to a possible aspiration pneumonia. Clients with either TEF or esophageal atresia, or even both, will have trouble eating. We'll see that they have coughing episodes, choking, or even vomiting when they attempt to eat. This occurs because food and oral secretions can accumulate into that proximal esophagus, that blind pouch, and can then be aspirated back into the trachea, causing coughing and choking episodes. This can also occur due to reflux within that distal esophagus that causes those secretions and food particles to travel back into that bronchus or trachea. We'll notice these clients will have drooling, excessive oral secretions, and even a frothy saliva when they attempt to eat. Abdominal distension may also occur due to, as you see in the illustration, the distal esophagus connecting to the trachea, allowing more airflow to pump into the stomach. During these choking or coughing episodes, these clients may even experience apnea or cyanosis. It's important to note if you ever auscultate coarse breath sounds in these clients, that is indicative of pneumonia. Clients will experience poor weight gain as they are aspirating this food rather than actually digesting it and taking in those nutrients. To confirm a diagnosis of TEF or esophageal atresia, the healthcare provider will attempt to pass a catheter down into the stomach. This will be unsuccessful, and that catheter will coil within that malformed portion of the esophagus. This coiling of the catheter can be confirmed on X-ray. If this diagnosis is confirmed, we need to prepare these clients for surgery. Now, it's important to note that these babies are typically newborns when they are diagnosed with TEF or esophageal atresia. Some may be experiencing pneumonia due to that aspiration and need antibiotic treatment before surgery. Some infants may not be of the appropriate weight or able to tolerate surgery right away, so it's possible surgery may need to be prolonged. This indicates the need for a gastrostomy tube, so these clients are able to feed and get nutrients prior to scheduling that surgery. This allows for them to eat safely. Aspiration precautions are one of our number one priorities, so we want to maintain an NPO status to decrease that risk. Also ensure that we're allowing the head of the bed to be at least 30 degrees for these clients. The healthcare provider will most likely order a double lumen catheter to perform low continuous or intermittent suction in order to suction out those oral secretions and food particles from that pouch of the esophagus. As with any client with NPO precautions, we want to administer IV fluids to keep them adequately hydrated. After surgery, we need to monitor these clients closely and slowly be able to see if they're able to eat safely and effectively. We still want to maintain that semi-upright position of at least 30 degrees when we do attempt to start feeding these clients. If we ever notice any choking or regurgitation, that could possibly be a sign of an esophageal stricture or even GERD or reflux. These symptoms are important to report to a healthcare provider. We do need to anticipate that this client is learning to feed appropriately and effectively for the first time, so we need to start slow and most likely start with sterile water as they are still at risk for aspiration. We wouldn't want them to aspirate any milk or actual food products. Monitoring for signs of tracheomalacia or weakness of the trachea, known as a floppy airway, is important. The classic symptom of tracheomalacia is a barking cough.